thank you for coming to the noon meeting organized by the Division of Health Economics. My name is Irina Sinanovic. I will be introducing a colleague of mine, Professor Susan Cleary, who will be talking about the role of economic evaluation in the current discussions around national health insurance. So she'll kick off with her presentation, but there will be plenty of time for your questions, opinions, ideas. We have until 1 o'clock. So over to Sue. And thank you very much for being available to share with us your opinions.
Thanks so much for coming, everybody. It's really nice to see lots of people that I know and some new faces too. So I'm going to be talking about a topic that I'm quite keen on, and so I've been doing a bit of talking about it. So I tried to mix up my presentation a bit in case anybody has seen it before. But it's a topic that I don't know the answer to. So that's why I was thinking about trying to have a bit of a discussion, because I don't think that there is necessarily one way of going here. And so what I'm hoping to be able to do is to talk a bit about the current public health system. And throughout my talk, I'm going to be focusing on equity and quality, not on cost effectiveness and efficiency. And so to talk about the current public health system and some of the things we know about in terms of the concerns with equity and quality. And then talk a bit about this notion of universal health coverage, and to the extent that there might be some opportunities in that notion to improve these areas of equity and quality, maybe through the application of economic evaluation. Maybe not. Up for discussion. And then how does that look like in the National Health Insurance proposal, and focusing particularly on this idea that they have of creating an explicit benefits package, and whether that might help us to move forward on equity and quality, and hopefully lots of time for discussion. So that's the idea. And please feel free to put your hand up or ask questions as I go along. So to start with the current public health system, Economics 101 likes to talk about demand and supply. So obviously we're dealing with a very complex health system, and the framework of demand and supply is just one straightforward way of trying to get to grips with some of this complexity. So on the demand side, we know that we're in a lot of trouble in terms of a large and growing burden of disease, and we all know about the issue of inequitable access to quality care. On the supply side, there's not much relief in the short term, because we know about the ongoing budget constraints and cuts, and we also know that there's a sort of sense of health workers and facilities being expected to do more with less. This idea of we must do more with less. So this is not new to any of you, but I'm trying to make a particular argument around it, so just bear with me while I go through some of the work that I know about that sort of speaks to the issues of the current public health system from a quality and equity perspective. So the first example is from a long-term project that ourselves in the Health Policy and Systems Division were involved in, along with lots of others in lots of other settings. And in particular, we did in-depth action learning, qualitative work, and one of the really common things that we heard about is the story of unfunded mandates. So a new policy comes down, it hits the facility manager's desk, it goes into a large cupboard with all the other policies, and there's typically no new resources available to implement this thing. And the quote is again in HR, when we look for HR approval, they kept on saying they don't have money, and the service, irrespective of no money, no room, no equipment, no personnel, it's expected that this thing is implemented with immediate effect. A very, very common story. The second example is a more quantitative example, and this is a survey of all 8 provinces. We tried to include the Western Cape, but it didn't work out anyway. A survey of all 8 provinces, and looking at issues of mental health system in the public sector of South Africa. And what we found was that there was very poor quality of care. I'm sure you're not surprised to hear that. For example, we actually have a Mental Health Care Act, and one of the things in the Act is that if you're going to admit mental health patients without their consent, so non-consenting mental health patients, you're expected to keep them in specific facilities in a special ward. And that's part of legislation. But yet, only 38% of facilities that were designated to provide the service actually had separate wards for their adult mental health patients, meaning that most of the time what you are finding is that these mental health patients who've been admitted not consenting are kept in general wards. The next example is to do with essential medicine stockouts, and surprisingly, I only found out maybe in the last 10 years that when we say essential medicines in South Africa, we don't actually mean that you have to have the things available in a particular facility. So we have an essential medicines list nationally, but provinces don't have to have all of those things within the facilities. So it's perhaps not surprising that we hear about these stockouts on a regular basis. And for mental health, lithium, for example, which is quite an important drug, was frequently stocked out in specialized hospitals. And the first-line treatment for major depressive disorder is also one of the most commonly mentioned stocked out drugs. The third example is also a quality example from the Office of Health Standards Compliance. And they are charged with auditing a selection of facilities across quite a long audit, a number of things that facilities are expected to comply with. And in the most recent report, the national average was just over 50%. Compliance is only achieved at 80%, and I think that anything less than 40% means there's a need for urgent intervention. So as you can see, irrespective of how you look at it, the vast majority of facilities were not able to be compliant with the national core standards. So nothing is news to any of you in this audience, I'm sure, but there's a certain narrative around these issues in the public health system which tends to blame health workers and health facilities for these problems. And my basic argument is that if the majority of people are unable to do these things, surely one of the reasons must be that there's too little money, right? One of the reasons has got to be that there isn't enough money to be able to do it. That's my basic argument. So, what I'd like to put forward to you is that we have these national policies and guidelines that are often world-class and are often extremely aspirational, but implementation on the ground is patchy at best, and my argument is that is because there's insufficient money. Okay. I don't think it's actually that controversial, but so this is called the UHCQ, but I've modified it for this presentation, and because I'm wanting to focus on the issue of equity, so the extent to which those who have an equal need for a particular condition actually get the same treatment. That's the definition of horizontal equity, equal treatment for equal need. So I'm focusing on equity, I'm focusing on quality, and I'm focusing on the things that we say are supposed to be available at a particular quality, and that I'm calling the benefits. And here, in this bit, is the budget that we have available to achieve these things. So the idea is that you want to be moving towards 100% horizontal equity, so moving towards equal treatment for equal needs. You want to be achieving the base level of quality that you can on the vertical axis, and you want to be expanding the benefits as much as you can. So you've got three dimensions that you're playing with within a fixed budget. So the idea is that what you're trading off is equity, quality, and the slope of the benefits. So in South Africa at the moment, we know that we have extensive inequities, we know that the quality is poor, and the benefits, I'm going to argue, are unaffordable. So the things that we've decided in national policy, I'm trying to say that the examples I've given of those things show that they're unaffordable. I'm not prepared to sort of argue that it's sort of because health workers aren't doing their job properly. The argument is that they're unable to do the job that they're set up to do with the resources that they have available to them. Okay. In such a context, one often hears that the way forward is therefore to allocate more money to health. And of course, it would be awesome if we were able to allocate more money to health. But if we look at the health allocations since democracy up till today, what we see is that as a percentage of GDP, our health allocations are pretty much at their highest level yet. So while obviously going forward, and one would want to allocate more money to health, the extent to which it might be possible to allocate more money to health in the short term seems to me to be very constrained. And so we have to look at reality as we find reality right now, in my view. We also know that things are looking pretty dire. The Auditor General doesn't have good things to say about the financial health of our departments of health, our provincial departments of health, and particularly with the rising medical legal issues, there are serious concerns about the budget going forward. So it isn't within this context that we find ourselves now that we seek to achieve this thing called universal health coverage, which is defined as providing all people with access to needed health services that are quality, sufficient quality in order to actually work, and in a way that doesn't expose the user to financial hardship. So the goals, therefore, are utilization of quality services when you're in need of them, and not to have to pay predominantly at the point of service. So financial risk protection is mainly about not paying at the facility. So obviously we pay for health services, but prepayment is the way to go if you want to avoid issues of financial hardship. So this framework that I'm putting up here is quite a nice framework for trying to visualize a bit more what universal health coverage is about. In the blue, on the left-hand side, are issues of health financing. So that's to do with how you collecting your money, tax-based system, or some sort of prepayment system, how you're putting your money, and then how you're using those pooled funds to purchase services. In the middle are the intermediate objectives, and in the orange are the goals that come pretty much exactly from that definition. So the goals are utilization relative to need of quality services in a way that doesn't expose you to financial hardship. And the idea is that if you work to achieve equitable resource distribution of cost-effective services that are transparent and accountable, you would be more likely to achieve these goals. So what I want to focus on in particular through this whole thing is this idea of the benefits. So they say that any country in the world can achieve universal health coverage. It doesn't matter how much money you have. And how can that be? The answer lies in the specification of these benefits. And so what the benefits are becomes actually extremely critical to your achievement of universal health coverage. So what are benefits? Well, it actually blows your mind because it's something unbelievably technical and detailed. And so basically it outlines everything that should be available in your health system. And probably you're dealing with standard treatment guidelines, essential medicines lists, and essential diagnostic lists, but it is unbelievably technical. But if you can choose your benefits correctly, you can achieve equity and resource distribution and efficiency through the use, so this is for the discussion on, right, potentially through the use of economic evaluation estimates. And if you do that in a way that's transparent and accountable through health technology assessment processes, the idea is that you also increase trust and social capital. So the idea is that if we can trust that these benefits are chosen in a really good way, within a fair process that is transparent and open to appeals and revisions with public participation, all that good stuff, then we can start to trust that our health system has our best interests at heart. And that process is called health technology assessment. And the technology part is very confusing for people because when they hear health technology assessment, they think of, I don't know, a cell phone or anything else. But it's not that. The technology is anything that we can bring to bear that might improve health. So it can be a model of care, it can be a way of doing things, it can be the organization of the health system, and it can be medicines and diagnostics and the normal things like that as well. Okay. So to summarize what I've got to so far, hopefully, is that on the pathway to universal health coverage, package. The choice of what services need to go into the package can be based on relative efficiency. Efficiency is just about maximizing outcomes within cost. That's all it means. And also, depending on how important equity is, you would need to consider whether this thing that's on the benefit package becomes affordable. So you can't achieve equity if it's not affordable. Equity and affordability very much go together. This can be assisted by the application of the broad methodologies of economic evaluation, and obviously this stuff rests on prior questions of evidence-based medicine to do with does it actually work, does it actually improve health. And also just to summarize, that these considering all of this evidence in a way can be brought to bear and can be considered within a process called health technology assessment, which is actually a procedural issue. Almost like a court of law. So you've got all of your evidence, but the process of health technology assessment is actually the committee and the leadership of the committee and the way that voice is given to different members of the committee. That's what health technology assessment is about. So you've got all of your data and you're sort of number crunching a bit, but you have to have this fair process that is sort of part of health technology assessment in order to make decisions. And if this is done well, can be very beneficial. Okay, any questions so far? Okay, so I thought I'd shed at least, some people have been in my classes, so that's great, but for the rest of you, I thought I'd just provide a little bit of an introduction to what is economic evaluation, given that it is part of the set of methodologies that in theory should be used to make these decisions. So economic evaluation is about comparison and choice in the face of scarcity. And so it can be defined as the comparative analysis of alternative courses of action in terms of their costs and consequences. It includes a whole bunch of stuff. And unfortunately, health economists keep inventing new names for these things. But basically what you're looking at is the cost of doing something and the opportunity costs of what you have to give up in order to do this new thing. So economics is very keen on this idea that in order to do something new, you have to consider what you have to stop doing in order to do this new thing. So there's not infinite resources that you can just always be spending more and more and more, particularly if equity is important to you. So these are the basic components of an economic evaluation. So you have, in the orange at the top, you have different types of costs and different types of opportunity costs. And then you have benefits. The consequences of using that money in a particular way gives you benefits. And there's different ways that we think about benefits as well. And in the middle, you have the new things normally that you're considering doing. So for example, your interventions can be straightforward, like this drug versus that drug. That's the easiest type of economic evaluation to do. But they can also be this form of model of care versus another form of model of care. So one analysis we once did was looking at nurse-based HIV treatment versus adherence caps. So it's a model of care question. You could look at task shifting questions. All that kind of stuff can be the intervention piece that you're thinking about. And then costs from a provider's perspective tend to be the things that you will see within a health facility, your health workers, medicines, investigations, equipment. But to the patient, and potentially the patient's carer, and potentially the patient's family, you have the opportunity cost of spending time seeking care, potentially lost income, potentially out-of-pocket payments, even things like traveling costs, money that you need to spend buying food while you're waiting in the facility. All of those things can, in theory, be considered. And then the benefits in natural units, we would normally have something like a cost per 5 months delay in disease progression. But ultimately, what we need for economic evaluation is a quality-adjusted life year or a disability-adjusted life year, because those are known as these multidimensional outcome measures, which allow you to compare, in theory, anything to anything. And for example, you might say, I have a cost, it's going to cost me $1,000 to prevent an HIV infection. I'm not able to compare that to $1,000 to treat a measles case, to cure a measles case. So the quality adjusted life here and the disability adjusted life here are ways of putting everything into the same measuring rod so that we can compare the cost effectiveness of measles to malaria to TB to cancer. So that is the idea behind it. And so if you're thinking that this sounds impossible, you're probably on the right track. I'll be fine with that. So the components to summarize is that normally what we have is this is, there's a lot more than that, but normally what we get down to is the cost of this thing, the cost of this other thing, the difference in the costs between the two things, the 3 or 5 or 50 things, and then the benefits, the outcomes of the one thing and the outcomes of the other thing, and the difference in the outcomes. And then we summarize these things in what's called an incremental cost effectiveness ratio, or an ISA, which is the change in cost divided by the change in benefits. And then it's not used in this sort of black and white way, but the idea then becomes that if you know that your incremental cost effectiveness ratio is $1,000 per poly gained, you compare that to this external threshold, the cost effectiveness threshold, which is a measure of the marginal productivity of the health system. Yes, it is. What that means is that it basically tells you the level of efficiency of the health system, the extent to which the health system is able to convert money into health. And the idea is that your new intervention should be better than what you are currently doing in the health system. And the cost effectiveness threshold gives you a sense of whether your new intervention might be better. And if it is better, doing that new thing will increase health in your population. If your new thing is worse, doing your new thing will reduce health in your population. So this stuff about cost effectiveness is, if you were to ever achieve the holy grail of having a cost-effective benefit package, which I have huge doubts about, it would mean that you could not reallocate any resources and get more health. So it's the most health you can possibly get, given the way you've deployed your resources. So it's a good thing. Efficiency is a good thing. So just to make that a little bit maybe graphical, and for those who visual like me, maybe a bit easier to understand. So this thing is called the bookshelf, I think, bookshelf, something like that. And basically what it does is it plots the amount of poly or health you can get for every $1,000 that you spend on the vertical axis. So this is how much health I can get when spending $1,000. And so obviously the higher this is, the better it is. Does that make sense? So a higher bar means that it's more cost effective, basically. And the width, so that's the height of the bars is to do with the cost effectiveness, and the width of the bars is to do with the budget impact, because normally we're dealing with equity in publicly funded systems. So budget impact basically summarizes how much you would need to spend on that thing in order to deliver it to everybody who had a need for that thing. So you've got all your interventions ran from most cost effective to least cost effective, and there's your budget, and the cost effectiveness of this intervention is your cost effectiveness threshold. So this is your least cost effective intervention in your health system at the moment. And so if you want to bring in something new, it would be better if the new thing were at least better than this thing. So that's your cost effectiveness threshold. It's sort of proxied by the most marginal or the least cost effective intervention that you're doing at the moment. Obviously we don't know, right? It's okay, we don't know any of this stuff. So the idea is that you've got new candidates, and these are more cost effective than some of the things that you're doing at the moment. And these other ones are less cost effective than everything that you're doing at the moment. So if you were to take economic evaluation into account in your priority setting, the last two you wouldn't do. You would say, this is not cost effective. If I bring in this new thing within my existing budget, which is fixed, I will reduce health in my population. That's what not cost effective means. So I get rid of those not cost effective things and I bring in the things that are cost effective, and look what it does to the existing package. Certain things are going to get bumped out and then they disappear. It's a big problem. But I don't have time to talk about, well, it's a big problem. I don't like a 5-hour lecture. So we have now increased the health within the same amount of money. We have now increased the health of our population, and the yellow bit here shows the amount of additional health we have gained through considering cost effectiveness. But this illustration is largely to try and give you a sense of what a cost effectiveness threshold is. So the basic idea is that your threshold is determined by your least cost effective thing that your health system is currently doing. And so if your new thing is better than that, then bringing it in could be a good idea. If your new thing is worse than that, then bringing it in by definition means that you will have less health in your population, which could still be okay, but it depends. So it needs a lot of thought, and that's why health technology assessment becomes quite important. So, yeah, I put this book up here in case anybody's interested. So one of the success stories with universal health coverage in low and middle income countries is Thailand. And they have a very small group, very similar to the health economics unit, who basically ultimately was this very tiny little group of people who applied economic evaluation to the Thai universal coverage program. And this book, I've read about half of it, it's actually quite nice, summarizes how they came to be in that position and what they managed to achieve. But the idea is that the fundamentals of economic evaluation and health technology assessment is about trying to improve health within an available budget. So taking the money into account in how you make your decisions in a way that hopefully will improve health or distribute health more fairly. All right, so that's sort of the background. So now what do we find within our national health insurance? So the one thing is that it has a huge equity component to it, which in some ways I love about it, but in other ways it makes me very worried. So there's a lot of rights of users, and this basically comes straight from the NHI bill. And the rights are to know what services are in the benefits package. Now remember, this benefits package is this absolutely mind-bogglingly huge notion, right? So to know what services are in the benefits package, to receive services free at the point of care, to be referred if the service isn't available, and if the service is refused to receive written feedback from the fund about why that decision was taken. So it's really powerful from an equity perspective. And if it were possible to do this, it would improve horizontal equity, meaning equal treatment for equal needs, and vertical equity, meaning those who are particularly vulnerable won't be more disadvantaged than they already are by the way the system is set up. How will the benefits be determined? According to the bill, there will be a benefits advisory committee, and they will determine the package of benefits, including the formulary, which is the drugs and the labs. And then there'll be a pricing committee that will basically say this is how much we're prepared to pay for these benefits. And this all sits under the minister, and it's pretty much appointed by the minister. And then in the fund, there's a very similar body that does very similar things, which is also a problem. So there's a lot of areas of overlap, which I think from a governance perspective is not a good idea. And I think getting these governance arrangements right is absolutely crucial to the extent to which we're able to achieve universal health coverage. We also know that the National Department of Health, with assistance from Clinton Health Access Initiative, has been working hard over a long time already to try and establish the health benefits package, which of course they've called something else. It'd be so nice if you had the name in the bill and then you use the same name. But anyway, they're calling it the Service Benefits Framework now. So they've started on this process, and you can read all about it in the latest South African Health Review. And I've got a couple of quotes. So basically what they say is what they're doing is documenting the conditions, services and care pathways reflected in existing national clinical policy. The next sentence is very important. What it says is this was an important starting point for considering the benefits, because NDOH is committed that whatever NHI does will be at least equivalent to what the public sector does. And that worries me, because my argument is that the current guidelines aren't affordable. So if you remember all my examples of medicine stockouts and inability to achieve national core standards and unfunded mandates, all those examples I put up there with the argument that what we are saying is the current package isn't affordable at the moment. So if we go into this NHI world saying that that is what we're going to do, we are going to need more money to do that on an equitable basis. That's my argument. And then they say that this is a baseline from which to revise these services over time. Okay, I'm nearly finished. So what I like about this explicit benefits idea, and I'd be so curious to hear what you guys think about this explicit benefits idea. So what I like about it is that I think that it will be really great, and I think that they will be able to improve the coherence of the national clinical guidelines. And if you read that chapter, you'll see that they basically were confronted with conflicting guidelines. Things don't really tally up. There wasn't the process of creating guidelines. It sort of differs depending on which directorate you're in. So if it were possible to at least create something that's coherent at the top, I think that would absolutely be a good thing. The other things that might be good about it is in the future NHI, it could provide some transparency to providers regarding what is expected of them. I've already talked about the entitlements to users, and so transparency to users is also in there, and there is a possibility of equity gains. But on the downside, is it even possible? So there are technical challenges. So there are, I think, 30 cost per quality analyses that have ever been done in South Africa. The mind boggles at how many would be needed for this NHI story. So there are technical challenges, there are data challenges, like we do not know what the need is or what the burden of disease is for all of these different things, never mind comorbidity, so it's very, very technically challenging. And then relational challenges. Can different national public health directorates actually collaborate to align clinical policy? Because at the moment, there's a lot of lack of alignment across directorates. And then also, for the governance colleagues, it's a very centralized idea. And we know from a governance perspective that centralization and top-down managerial structures can be very demotivating. And if it's not done well, it can be even more demotivating. So it's sort of, we've been talking about decentralization for ages. This is, in a way, a centralization. And so I have quite a few concerns about that. So to summarize, the point that I'm trying to make is that we have a certain amount of money, and we need to think about the trade-offs in terms of how we spend that money from an equity perspective. Do we want to put more money to achieving equity? From a quality perspective, do we want to put more money to achieving quality? Or from a benefits perspective? You can't have 100% on everything. This is my attempt to draw what NHI maybe is sort of visualizing for themselves. So moving more of the budget to equity seems to be what is proposed, and also moving more of the budget towards quality, therefore requires the benefits to be restricted. Does that make sense? That's the basic point I'm trying to make. It's like you can't do all of them at the same time if the budget is fixed. And the other part that I'm trying to argue is that it's wise to assume that the budget is fixed, because it sort of puts us into the reality that we actually live in, as opposed to the sort of fanciful reality of utopia that never gets achieved. So with NHI, we know that we want to move to absolute equity. We know that we want to improve quality. But what does that then mean for what are the benefits? Thank you.
Thanks very much, Sue. So you ended your presentation with a question mark. So there is a question to you in the audience. What do you think about the last slide? Or any other comment, questions you may have? So,
thank you. Thank you for an interesting talk. You have explained the two mutually incompatible problems of insatiable demand versus limited resources, as here, as in England, the National Health Service. And as long as disease and injury management, and I use that phrase deliberately because to talk about healthcare confuses the issue. Healthy people don't need care. If disease and injury management are free at the point of consumption, the financial and logistic problems will remain. And something needs to be done to reduce the demand. And the corollary of that in England, 70%, that's 70% of what fills the beds and the waiting rooms is self-inflicted. I have not seen a comparable figure for South Africa, but there's certainly an opportunity for some research to be done.
Thanks. That was more a comment than a question.
Yes. Well, you invited comments.
I did. Thank you for your comments. Christine, Virginia.
Yeah, thanks very much. Really interesting. I want to ask you how you reconcile this that we have to constrain our benefit package with the findings that I've seen in health economics that show South Africa has got very poor health outcomes for the huge amount we spend on health. So how can we not work with that and see where there's poor value for spending and take that out? And then we'll be able to do a hell of a lot more with coverage and equity and benefits packages. So work on,
So what you're talking about is disinvestments, and I absolutely think that that's what we need to be thinking about. And I've often spoken about that. I didn't speak about it so much today. I've spoken about that a lot. And that's why it worries me that they say that the NHI would be at least what is on paper at the moment for the public system. Because where are we going to find the money for that? And I agree, we need to look at the disinvestments. In terms of value for money, I think that stuff is more to do with the private sector. So I don't know if you just looked at the public sector whether we would look so bad from a value for money perspective. Because we're the second worst in the world after America. But I think it's driven by the private sector, that stuff. But I think you're absolutely right. If it were possible to find a way of removing some ineffective things and cost ineffective things from the health system in order to do better from a quality and equity perspective, I would be quite keen on that. I think that is the way to go. And I think that could be done by the province. But I am pleased that National is at least starting to think about the national clinical guidelines, and I do think that that's a step in the right direction, and that is their mandate. And so they could do a lot better at what they set at the top as the things that we're supposed to be doing. That certainly would be better for health facilities and health workers. But I'm not sure if there's political appetite for disinvestment at the top. And so it might come down to the province needing to think about disinvestment in order to achieve better quality.
With the last slide, as you adjust your quality access and your equity access, obviously the shape shift, and but it seems the budget more or less stays the same. But isn't one of the goals of the NHI theoretically enlarge the budget as well? I mean, because the idea is you're going to be getting contributions from people who previously would have been contributing to, or it's forced contributions to this fund, and then they won't be contributing to private medical aids anymore, so there will be a relative big increase in money coming to them with proportionally fewer new people coming into the system. So theoretically the budget should shift a little bit. Has that, in a sense, been quantified kind of percentage-wise? How much do we think the budget will increase if we implement this?
So I think that there have been a lot of attempts to look at that question, but my sense is that we won't know really until we start getting there. So it depends on a lot of stuff. It depends on whether people do need their medical aids or not. It depends on whether the economy grows. It depends on whether there's sort of a willingness on Treasury's part to increase taxes. So personally, I think what we need to think about in the next 5 years is what we've got at the moment and do well with what we've got at the moment. And as more money comes, it's relatively easy to think about good investments for that money. But we aren't ever going to know. We have no idea what's going to happen in 30 years' time. So I think we should think about what we've got at the moment. And there's too many unknowns for me in terms of what's going to happen with medical scheme membership. And if you look at the bill, it does talk about changing the role of medical schemes to only providing complementary cover, but only once NHI is rolled out. And nobody can say what rolled out means anyway. So it's hard to know. So my basic point is that we need to look at the money we've got at the moment and spend that well. And there might be money in 15 years' time, no problem, and that doesn't mean that looking at the budget as fixed for now is a bad idea. I really do think that thinking of the budget as fixed for now is the way to go.
So just to comment on that, I mean, I think it's not quite as stark as that. Because the whole point of NHI is to try and use the current spending on health per GDP for everyone. As we know, about half of the 8% goes to the public sector, half to the private. And the idea is to try and get all 8% to go to everybody. I mean, that's the whole point of the NHI. So probably you won't get as close, you won't get 8%, but you might get, so the idea is to get in the region of 7% or so that we can get. And the idea being that people be more willing to pay more taxes towards health if they don't have to pay medical aid. And if they can get the same or similar or better outcomes based on that. So, I mean, there is already the premise that in the private sector, just the figures themselves, just taking 4% of GDP versus the number of people, even if the outcomes are good, the cost per outcome is obviously, it's ridiculous. So, if you put the HTA approach to that, then a lot of those should disappear. And as we know, a lot of that is due to over-servicing of a particular health problem, over-servicing of that. And also efficiency gains from buying services for a bigger group, one fund, should also decrease that. So on all those counts, the NHI, if it gets through as anticipated, should improve things dramatically on that. And so one shouldn't be looking at that 4% GDP, which is just the government spend. We should go, I mean, you can be conservative, but it should at least be a bit above that. So we can get there.
But not in the next 5 years.
Well, hopefully we can already get, I mean, it's a political issue, but I mean, already the tax rebates that you're getting, I mean, that's an instantaneous thing that can be done immediately. The stewardship of the private sector is something that can be reasonably quickly implemented to prevent over-servicing. And that's not that difficult to do. But it requires the commitment to do that. So those gains will quickly come in if we go ahead with it. But also just I want to comment on your Prof. On your diagram there. It's great, but it's not as clean as that, of course.
Sure.
I mean, it's way more messy. And so yes, hopefully you move towards equity, but some of the benefits would not extend to the full population, obviously. And so it's issues of access and issues of availability of particular services in any particular area would be there, as well as rationing of particular services. I mean, because now rationing is the other end of HDA. So by definition, you're saying that this is not a very beneficial service in terms of efficiency. However, it's a service we want to provide for various reasons, and hence we ration it to a special group from whom we hope the benefits will be highest. And it might not quite be that, but, you know, and that will push it so that instead of getting a rectangle, you have a strange polygon shape there, obviously.
Thanks. That's a good comment. Thanks very much.
Thank you, Sue. I agree with your thesis, and I think it's a really helpful model. One of my concerns is how we managing or not managing resources that seem to me to be potential for low-hanging fruit. I mean, whether we increase the budget, whether we can or not, we're just going to increase the quantity of inefficiency. We know, for example, in primary care that we're not committed to nor we practice in cost-effective primary care. And when that is practiced, universally the health outcomes improve and the costs go down, and equity also improves. And that doesn't cost more money. You need commitment and then need more training. And I wonder to what extent we could get more benefits on that axis, say, and improve quality with just tweaking things that we know we need to tweak, that need to improve.
I really hope so. Yeah. But that is the benefit of considering cost effectiveness, is that with the same amount of money you get more. So that is what I think we need to be doing, thinking about. Yeah.
So that would be in your intervention.
What is in the package? Yeah. So I didn't go too much into cost effectiveness per se, because sometimes that's seen as being mean. I don't know. Maybe the time has passed. So that's why I tend to talk equity, because actually cost effectiveness and equity move in the same direction. But equity, I think, is a message that we all buy into, but cost effectiveness isn't necessarily. So that hence the angle that I try to take on these things.
Marsha? Thanks, Sue, for a great talk. I really like that you sort of situated the work in this kind of broader health technology assessment, because it does speak to the sort of political nature of using economic evaluation. And I was, because it's, I mean, you agree, right? It's not just simple, we will take these off and we'll keep these.
It's a massive thing.
Yeah, and so I wonder, what do you think the political appetite is for this kind of, these contestations around the constitutional right to health versus trying to remove something?
Yeah.
And I mean, are we imagining like removing some benefits that are a few drugs, or are we imagining removing whole-scale services? So I just wondered your thoughts. I know there's no right answer. I'm just, what are your thoughts?
So I think that my discipline requires me to not have a strong view on that, on what we put in and what we don't put in. My discipline requires me to follow process and look at evidence. So I can't, it's not for me to say we need to scrap this cancer treatment, for example. And I think that would need to be something that the officials in the departments of health looked at, ideally within some sort of a fair process. It doesn't have to be called health technology assessment, but a process that is transparent and with appeals processes and open to revision, all that kind of good stuff is needed. But I would, from my perspective with health economics, it's important that we stand back from individual issues and try and look more broadly at the whole thing from an efficiency, equity, affordability perspective. But I would just be keen for that kind of thinking to be happening.
Yeah, I agree. Yeah.
And I think the politics and the governance stuff is absolutely front and center concerns, and there would need to be major political will to take economic evidence into account. And we also can see from the experience in other countries that it can be very contested. So one of the things about being explicit about benefits is that it opens things up to contestation in a way that implicit benefits don't. And obviously, individual patient groups have a very strong view on these things, and the media often will spin those messages in a way of the cruel and uncaring health system that isn't prepared to fund cancer drug X that can extend life by 1 month for $100,000.
Yeah.
So as health economists, we try and sort of stand back from that stuff and look at all needs sort of dispassionately.
Thank you very much for that. It was a really helpful presentation. The visuals are very helpful. There are just 3 assumptions that I find. One you've already alluded to is that the political will is rational and evidence-based. But the other 2 are the assumption about what is health. I was very interested to hear that you talk about medicines and disease. Nobody ever talks about a disease service. They talk about a health service, when in fact the focus is so often that. And if we aren't clear about what we actually mean by health, then whoever sits on the Benefits Advisory Committee is going to be driven by their own lens of what health or disease is and what is valuable. So I think that is a critical piece to be able to address. The other thing is that you've talked a lot about the budget at this stage. We should assume that it is fixed, and you've talked about costs. And I see that this is, your presentation is really within the health sector per se. But where there are other resources in terms of social capital and strengthening social cohesion and communities and that sort of thing, surely this is where we need to be having some joined up thinking beyond the Department of Health, but with other organs of government, civil society, and that sort of thing, so that we decrease levels of violence, that we decrease what's happening on Saturday nights in the trauma units, so that we free up people and resources for things that are going to give much more lasting benefits.
I agree. Great point.
My point that I was going to make was exactly the same as Sheila's third point, except that I was going to ask how much buy-in is there at the moment from housing, from all of the other sectors that could very much influence our budget. How much buy-in is there from them in terms of their budget?
And I guess very little. Any other views? My husband works for the City of Cape Town, so based on what he tells me, because I mean they have that budget, right? So across all of these different areas.
So what are we doing towards that? And similarly in education, if we're saving all of these children, all of these things, they're going to need to build bigger schools because we're giving money for the robots in. So the repercussions along the line in terms of everybody else, what do we then, maybe there isn't, but then what are we, surely our responsibility then to say, yeah, you guys need to be on board.
Yeah, I mean, I think, so I completely simplified the components of an economic evaluation for the purposes of this talk, and it's possible, obviously, to apply that thinking to anything you can imagine in any sector and across sectors. But in theory, in practice, what would people make of it? Even in the richest country in the world, they struggle to do this intersectoral cost effectiveness analysis and actually use it for policy. And then there's also complicated things about the reference case, which I didn't get into, which speaks to some of your issue about the time frame of the analysis and the intergenerational effects and so on. There's all that. So in South Africa, we don't have a reference case at all. And so for me, step one would be getting agreement on the methodology that we're going to use to make these decisions. And we can have a big debate about that for a number of years, and I think that would be really helpful, so that we get to a point of saying, this is how we're doing this stuff, so that we can actually move forward in a way to make decisions that we can defend and justify based on the approach that we're going to take. So the theory can accommodate your points, the everything's going to be so different from how it is now from a data perspective that I'm not that worried about that part of it either. The politics is the issue. The politics and the governance is the issue, and the leadership.
Do you want to make a comment?
Yeah, maybe she really added to it, but I mean, that's the problem with how technology assessment is. And not only is it so difficult to cost all the technologies or even to split them into discrete units, but when you're looking across sectors, and this is typical things that come up in provincial and national departments, they end up fighting each other for budgets. And of course, then the outcome then is not a health outcome. You know, to do the total public good outcome. And I mean, if you can't measure a health outcome really well, try measuring a public good outcome, and so on. And of course, there's, as you mentioned, the repercussions of health outcomes. So people would argue that health outcomes for young children, the benefits extend way beyond the daddies that you can get from them. So if you have better outcomes, early childhood development in terms of nutrition, education and stimulation of children, it benefits not just them, but the future generations, and also it benefits not just health, but it decreases crime, increases social cohesiveness, and so on. So the total public good for that is way greater than perhaps at the other end of the spectrum, at the older age, and so on. And I mean, so probably with the NHI, what we're going to end up is new technologies will get this, and existing ones will just stay. And then the other thing also where it comes in here is that makes it difficult is that benefits, improvements in quality can come at zero cost or less cost. And there isn't necessarily that we have to increase the budget in order to get better quality. And similarly with benefits. You know, so the way in which services, so if services are provided in this particular manner, then that's what you're going to get for it. However, if you change the way that's done, improve upon that, so the technical efficiency then affects, you know, the celebrated efficiency that you're looking at. And so it's a moving target, besides the fact that being so difficult, and it's another problem that you're stuck with. So again, I can only see for new stuff. And only for health. And the other sectors need to fight it out on another level between themselves, on some assumed public good.
I agree, and I think that's an important point. So it's almost like our NHI framework is assuming that we're going to apply some form of economic thinking across everything. But yet, in most countries where health technology assessment is done, it's only for the new stuff. It's not for the existing stuff. For example, in the UK, which is the most celebrated example, it's only the new stuff that they look at. And they've never really thought about the stuff that the NHS has always been doing. And then also, what they admit that they do quite badly is they might look at the cost effectiveness of the new stuff, but because the budget is fixed, even in the UK, they don't look at the opportunity cost of the disinvestment explicitly. And so they've tried to work out where disinvestments are likely to come from in the UK context. So you bring a new cancer drug, because it's been improved by NICE, it now has to be part of the benefits. The UK is a bit like our public sector at the moment, whereas where most of the stuff is sort of decided on in each jurisdiction, and so there's the postal code lottery and inequity across jurisdictions, except for things that NICE has approved. Those things have to now be provided by all jurisdictions. And so what is the opportunity cost of bringing that thing in? Apparently largely mental health. Because not a particularly active lobby group. Difficult for people with mental health patients, mental health conditions to advocate for themselves. So that is a very, very big issue, and I agree with you.
Pretty good. You can close here. Thank you very much.
Thank you.